Much like biostatistics, regulatory issues are going to be a significant portion of the exam. So I'm going to talk about some basics as far as agencies, as far as Joint Commission, different things associated with various agencies and what exactly they do and how they impact our world as pharmacists, because certainly some regulatory questions will come up, as there's a substantial percentage in the BCPS content outline dedicated to regulatory questions. So one of the most important kind of regulatory agencies is the Joint Commission. This is actually a group that evaluates and accredits healthcare organizations. And this isn't a non-profit group. And the accreditation process, the scoring, the judging, the grading, if you will, of hospitals, the accreditation of a hospital, is based on quality of care. And there's lots of different factors that go in here, but the Joint Commission is going to look at, are you adhering to best practice performance standards? Okay, so that's really what the goal of the Joint Commission is doing. Is they are making sure that your organization follows the best standards and is providing high quality care to patients. Okay, so Joint Commission aims to ensure healthcare organizations provide quality, safety, efficacy, making sure that patients are getting in and getting out of the hospital appropriately. And then, of course, value-based care. They're getting their money's worth. Now, the Joint Commission survey process, I'll kind of run that through you a little bit, give you some pearls on that. It's an unannounced visit. The facility usually has a time frame that they know they're coming between. 18 and 36 months window is typically where it's at. Now, this is an on-site visit. Okay, so they actually come out to the site. They don't just submit for information or ask questions over the phone or televisit or anything like that. They actually come out to the site. Deficiencies. So if they find that the facility is not doing something up to standards, they can give a deficiency, and that deficiency is called a requirement for improvement, or an RFI. And entities must show, if they want to retain Joint Commission accreditation, entities must show that they're responding, that they're doing something about that RFI. And so what they're going to have to do is submit a plan of correction. So let's say that Joint Commission found that nursing staff was inappropriately administering a medication. Okay, so what leadership, what the institution would need to do is create a plan of correction and evidence of standards compliance to show that we're maybe educating nursing staff that was incorrectly doing that. So we provided education. Now maybe we would need to do some internal auditing to make sure that nursing staff is complying with that new or altered best practice procedure, and kind of continued monitoring and follow-up to ensure that plan of correction has been implemented and has been changed. So the little bit more details on the exact survey process. So when surveyors get there from Joint Commission, there's kind of an initial planning session as to what we're going to look at, where are we going to go, what are you going to show us, that type of thing. Orientation conference, and then, leadership session with leadership of the hospital, the healthcare organization. Tracer method of review is kind of what the Joint Commission is going to look at, their process for looking at things, and I'll talk about that in a little more detail in the next slide. Competency assessment, looking at what's going on, and is hospital staff up to competence and levels there. Review of credentialing, so looking at providers credentialing and scope of practice and different things of that nature. Environmental review, they will look over the building as far as cleanliness, and you think about dietary and food issues and things of that scope. And then of course the exit conference, where they identify potential issues, report back what they found, the good and the bad, and leave the healthcare institution, healthcare organization with some guidance on what potential issues they've seen. Now the tracer method specifically, so this is kind of the review process for the Joint Commission surveyors. What they do is they kind of go through the patient care experience, maybe from arrival into the hospital, if they get transferred to different units, maybe that transfer process is going to be looked at, the care at each individual location that patient is at, what happened. From a medication perspective, how did the medications get there? Did the nursing staff administer those medications appropriately? Was the patient properly educated? Was there follow-up done to ensure that those medications were effective and that they were safe and that they were appropriate? If there was an issue, a side effect, something going on, was that adequately monitored, documented, followed? So I think you kind of get the point of that tracer method and looking at each process throughout the patient care experience. So again, it looks at how well services were integrated. Is pharmacy communicating with the nursing staff, coordinating with the primary care provider, the hospitalist, whoever the physician is there. And then of course, like I talked about, that medication process, medication management is an important thing to us as pharmacists. And so, Joint Commission could look at everything from, IV compounding to the development, the production of that medication product, to the monitoring, tracking of adverse events or medication errors upon administering that medication product. So lots of different aspects when you think about the whole process of how medication gets to the institution, to the patient, and follow-up procedures after that. So the Joint Commission and ORYX. ORYX is publicly reported quality data. Okay. So this incorporates quality measures into the Joint Commission accreditation process. So ECQM, that may be an abbreviation, you see electronic quality measures. And Joint Commission is working closely with CMS on identifying, what are the best quality measures, quality data that should be tracked and monitored. And with the quality data, this is going to help Joint Commission identify potential weaknesses of different organizations. So maybe quality metrics on, statin use post-MI. Maybe they're very poor in an institution. Maybe that's a quality measure Okay, so I think you can kind of get the point of, best practices, standards of care in quality measures. That's what we're trying to do. So those accountability measures do change. They can get altered over time. And I've got some examples here on the next slide. So here's some kind of historic examples of quality measures. Again, Joint Commission, different organizations may alter, may suggest changes to these quality measures. So these are kind of historic examples that have been in the past anyway. Acute MI. So again, kind of like I mentioned, standards of care in acute MI and use of medication management. Tobacco treatment, tobacco counseling. Is that being done? Is that being offered? And success in treating patients there. VTE, there's standards, guidelines for venous thromboembolism. Are those standards being adhered to in prevention, in treatment, management? Substance abuse, another historic example of quality measures. Asthma care. Certainly are we seeing patients come into the emergency department all the time? Is asthma medication standards up to snuff there? Perinatal care, some quality measures there. Immunizations, certainly influenza vaccination rates, pneumococcal vaccination rates. Certainly you could understand how those could easily be measured and really are best practice for various groups of patients for sure. So the Joint Commission accreditation process, it is 100% voluntary in that hospitals do not have to do it. Healthcare organizations do not have to do it. Hospitals, clinics. So, you might think to yourself, why, go through this process altogether? Well, it's becoming a source of recognition by payers that you become Joint Commission accredited. Obviously, that's potential to impact the bottom line. So that is a definite downside there. Certainly, competitive edge, as far as you being Joint Commission accredited. It's a label of potentially prestige, saying you voluntarily go through this survey process, even though it doesn't maybe seem like it's voluntary for larger healthcare organizations. Certainly the public appearance, if you do well on Joint Commission survey and prove you're adhering to the highest level of standards, that looks good to your patients and people coming into your hospital. Ensuring best practices are being utilized and followed, and Joint Commission does look at that through quality metrics and best standards. Also, it may reduce costs in the sense that as far as liability insurance and things of that nature, if you do have Joint Commission accreditation, this can be reduced, which can obviously be a cost savings there. Now, as far as medication management with Joint Commission, these are things that they might look at, might think about, handling of high-risk medications or hazardous medications. How is that done? Is it done in a safer manner? Are we doing extra steps to ensure that those high-risk medications can't get to our patients? Look-alike, sound-alike list, it's an important thing to have, to recognize, and tailoring that list to maybe each specific unit based upon the medications that they use in surgical versus, maybe a clinic setting within that healthcare organization. A formulary approval process, so what goes into that, who's a part of, that committee and that approval process. And then also recognizing that in rare instances we may have to have non-formulary drugs be used. So what is that kind of non-formulary process to get a patient necessary medication that isn't necessarily on the healthcare organizations or the hospital's formulary. And then, of course, storage, with medication management, which could involve everything, from preparation to labeling to beyond use dating and the scope that provides. Security. You think of, drug diversion, controlled substances. Are we adequately securing these medications from public, from the other staff that should not have access to medications? So I think that, storage, handling, preparation of medications is a huge deal for Joint Commission and for, best practices in general. As far as drug selection, so criteria for drug selection, what's going to be looked at as far as, developing the formulary and selecting medications on that formulary. Effectiveness, in particular, cost effectiveness, which I have the cost list down at the bottom, but certainly both of those play a role in which medications that we're going to select for formularies and different things. Drug interactions, so, are there risks on the drug interaction side? Are there medications that we always use in the hospital that maybe a new drug we're considering adding interacts with? That safety side of thing, as far as drug interaction goes, is an important aspect. Indications for use, that's definitely going to be looked at, considered. Potential for, medication errors. Does it look alike? Does it sound alike other agents? Is there a potential for abuse with our, challenging opioid addiction crisis going on? Is, a medication we add to the formulary going to contribute to that problem, or is that something we need to have a higher awareness and monitor for more closely? Adverse drug events, so certainly, side effects, the safety side of thing for drug selection is an important thing. Sentinel events, so is there situations that are really, really high risk that can place our patients at risk and associated with a medication on the formulary or criteria for drug selection there. And then the population served, for example, pediatrics versus geriatrics. Is this a hospital, a pediatric hospital? Well, yeah, certainly that's going to impact which medications you select to be, part of a formulary. And then any sort of, other risks or unique clinical aspects of a medication that may play a role. So process for drug events. So a hospital, an organization needs to have some sort of process of identifying, errors, drug diversion, adverse drug reactions, and, particularly the Joint Commission does care about this. Are you tracking medication errors? And to take that example further, what are you doing with that data? Are you just simply throwing it in a file folder? Are you having someone actively review that data, looking for trends, looking for maybe areas of the hospital that have a higher reporting rate, or maybe areas of the hospital that have a specific issue, have had numerous errors with a specific medication. Okay, when we see trends that are similar and errors that are similar, we need to take a look and say, okay, what's going on here? And that's really what Joint Commission is looking for. Same with adverse drug reactions. Okay, we have a high incidence of adverse drug reactions, red man syndrome being reported from such and such unit. Well, do they understand that we need to extend the rate of infusion or the time of infusion with that medication? So just simple things like that, as far as tracking adverse drug reactions, identifying trends to locations, to medications, to staff members that may need further education. We may need to change a system process to try to reduce any sort of errors or adverse drug reactions. So again, tracking, collecting data, errors, controlled substance. As far as patient safety, are we doing bar scanning? Are we scanning the patient? Are we scanning the medication? Is that being bypassed for some reason? And kind of looking at all that data and continuously reviewing that data over time as we get more information to really do continuous improvement and try to be better every day. So again, a hospital, the healthcare organization needs to take action on data that is, showing challenging trends or disturbing trends. So CMS, this is a federal government agency, basically. The CMS does fall under the umbrella of Department of Health and Human Services. And CMS is in control of Medicare and Medicaid, primarily is what they do. They're the payers, basically. And with Medicare, there's different parts to Medicare. So Medicare Part A, that generally involves hospital, skilled nursing, and hospice care. So I know in my background of long-term care consulting, you always hear of patients on a Med A, and that means Medicare Part A stay. And again, that skilled nursing can be covered for a period of time, as well as the hospital stay of the patients. And hospice can also be a Medicare Part A benefit. Now, Medicare Part B, this involves kind of more of the maintenance of the kind of chronic preventative type care. So clinic, lab monitoring, imaging, a lot of the diagnostic things. And Medicare Part B is a thorn in the side for pharmacists, as we're continuing to seek provider status, because pharmacists aren't considered providers under Medicare B. So doing any sort of activities within a clinic, pharmacists cannot independently bill under Medicare Part B at this time. So we're working certainly towards changing that and becoming recognized as providers under Medicare Part B, so we can independently bill for things. But at this time, it's why pharmacists need to do incident to billing and different billing strategies if they're going to be involved in clinic work. Medicare Advantage, Part C kind of puts everything together, Part A and Part B. Often, might include other preventative things, vision, hearing, possibly prescription drug coverage as well. Medicare Advantage plans often require networks. So you'll be in network within a specific healthcare institution setting. Medicare Part D, so this is the outpatient dispensing pharmacy benefit. And so this is your kind of classic MTM, medication therapy management codes are under this benefit, your CMRs, your things of that nature. So, more of an ambulatory outpatient Medicare Part D benefit there. And then obviously, drug coverage. Medicare Part D covers medications. HCAHPS, so these are a hospital consumer assessment of healthcare providers and systems. Basically, in my mind, HCAHPS are patient satisfaction surveys. So these surveys get sent out to patients, how'd we do? And ask a bunch of different questions. And this is a CMS mandate that hospitals do these assessments. And with the satisfaction surveys, an example question might be, were you educated, were you taught about, side effects of the medication upon discharge? That importance of recognizing, is the hospital doing that adequately? Now, certainly there's a level of, we did this, but did the patient remember, and so on and so forth. So there's always challenges with patient satisfaction surveys, but hopefully, getting enough volume of this does certainly show that we're doing all the things within that survey. So this patient satisfaction survey, HCAHPS, these surveys allow comparisons of hospitals from a patient perspective. And surveys sometimes, and can and are, used as payment incentives or disincentives, where if your survey results, your patient satisfaction surveys aren't high, you can certainly be disincentivized by payments becoming less. So CMS can retract payment based upon those surveys and different things like that. So definitely an important thing to monitor, an important thing to track, and definitely look at recognizing elements within that patient satisfaction survey that your institution is weak at, and certainly trying to do some education and change things to improve that. So like I mentioned, if patients are reporting that they don't feel like they're getting adequate education about their medications, well, that's definitely going to be an area to target. Is pharmacy doing an adequate job? Do we need to involve pharmacists more on that patient education side? Or is nursing just doing it now? Should we switch to pharmacy doing it? Do we need to educate nursing further because it's not practical, or pharmacists in our small hospital aren't available enough to be able to do it? So do we need to do some further education for nursing staff? So again, recognizing areas of weakness and really developing goals, plans, and solutions to improve those satisfaction surveys. So ultimately, HCAHPS goal is to increase transparency, help consumers in determining kind of best quality and quality of care provided. LEAPFROG is a nonprofit organization that collects and supports public initiatives to improve safety. So really the goal of LEAPFROG is to reduce kind of unnecessary healthcare injuries. So the LEAPFROG hospital survey that's been developed really allows that comparison between institutions, and ultimately the goal to improve safety, reduce errors, injuries, preventable infections. So lots of different things kind of tied into LEAPFROG in this organization, but they really do a lot of work as far as data collection and focus on the safety side of things through surveys and different methods that way. HIPAA, so this is, I think the majority of pharmacists are well aware of HIPAA and kind of the requirement standards for handling patient information. Really the goal is to protect our patients from unauthorized utilization of personal information. Okay, so this the HIPAA legislation also provides access to healthcare professionals who need the information. So it basically allows access to information, but it also sets aside situations where certain individuals shouldn't be allowed access to the information. HIPAA also tries to stay out of the way of research, clinical data, de-identified data for studies, and improving the quality of care. So it does definitely have some way outs for that. As far as some HIPAA violations, some concerns there, I just wanted to put down a few examples. Really, HIPAA violations or releases of inappropriate information is anything that could possibly reveal a patient's identity, condition, in an outside environment. If you're talking about a specific patient and you're in a confidential area, with a provider and a nurse and a pharmacist, and you guys are talking about a specific patient case, yeah, certainly that's, normal, everyday environment there. Now, if you're discussing a specific patient, and you say this patient by name, room number, in a public area, so in the cafeteria, and you're obviously identifying that patient, that's an issue. Obtaining more information than is necessary to treat the patient, that's an obvious issue with HIPAA there. Releasing information about minors without parental consent, kind of another example there. Simple things just like leaving sensitive documents in a public area, leaving computer screen open in a public area, and not logging off. Maybe you leave a patient's name up there so somebody can access their medical record. That technically is a HIPAA violation. So you just need to be aware and be paying attention as far as monitoring the safety and the protection of our patients' health information. FDA, so this is a big regulatory agent, a very important regulatory agency as far as medications go. So their biggest role, I think, from a pharmacy perspective, is their role in drug approval and monitoring. So FDA, they set whether a medication can be given over the counter, whether it needs to be a prescription medication behind the counter. FDA monitors drugs after they've been released, as well as the approval process, which I'll talk about in more detail as well here. In addition, FDA does have regulatory oversight of supplements as well as food. Now, in my mind, they really don't maybe do as much monitoring of supplements as I would like. Supplements are, I think, kind of hands-off for the most part, unless there's a specific complaint or obvious concern with a supplement. Then the FDA certainly has rights to go in and review what's going on with the safety of maybe some supplements there. But they don't directly approve supplements, okay? They go in after the fact if there's a potential reported safety issue or concern that way. CDER, So this is Center for Drug Evaluation and Research. So this is part of the FDA, and you can maybe classify it as part of the FDA's role, but specifically the CDER looks at drug safety and effectiveness. They review new drug applications and are a huge role in that approval process. So again, OTC approvals, prescription approvals, drug removal or restrictions from the market. The CDER kind of monitors and tracks that. Also, they look at good manufacturing processes. So they may go in and inspect and do various things with drug manufacturers as well. EPA, so this is a division of medication error and prevention analysis. This is a further kind of breakdown. They're under the CDER umbrella, again, which is all under the umbrella of the Food and Drug Administration. This division, this kind of subgroup, looks at medication errors and events. This group, under the umbrella again of the FDA, ultimately works closely with ISMP. So this is the Institute of Safe Medicine Practice, as well as USP, United States Pharmacopoeia, which is obviously has an important role as far as production, manufacturing, and all that sort of stuff. So ISMP, Institute of Safe Medicine Practice, a nonprofit organization. They have a voluntary medication error reporting program, MERP, they term it, or it's the acronym for it. They report these medication errors that are reported by individuals, healthcare organizations, and so on and so forth. They report these events, these errors, to the FDA. So ISMP, a really good organization that kind of tracks a lot of these safety issues and helps identify trends. If we're having the same issue, or if you see 2, 3, 4 different medication errors on a look-alike, sound-alike, maybe it's morphine and magnesium. Maybe there's been an error that's committed at multiple different organizations. ISMP can help kind of collect that data and report that error issue, and maybe recognize and report back some different ideas as to how to improve the safety and reduce the risk of that look-alike, sound-alike error. Again, they can kind of send out, ISMP sends out a newsletter that maybe you've seen as a healthcare professional, but just different good catches, different medication errors, trends, patient-reported issues. Maybe it's measuring volumes with syringes. Maybe there's different products that way that have caused issues. Anything kind of associated with the use of medications and medication error, ISMP is a good resource. They also have a really nice list as far as medications that should not be crushed. I've definitely used it a fair number of times. So you can take a look at the Do Not Crush list by ISMP if you just want to Google search it and take a peek at it. It's a really nice resource if you do have to review medications that should or shouldn't be crushed. ISMP does have a vaccine safety kind of reporting program. It's separate from the MERP, the Medication Error Reporting Program. It is voluntary. It's vaccine errors. Good catches certainly can be reported as well. VAERS, so the Department of Health and Human Services, within the federal government, has their own kind of vaccine adverse event reporting system. And, this is to, catch disprove, whatever terminology you want to use. But this is to track the safety of, marketing of vaccines that have been that are currently actively being used. Okay, so this is a post-marketing vaccine reporting only. Again, it may be hard to identify some abnormal, unique reactions in clinical trials because we don't necessarily give the vaccines to millions of patients in clinical research and clinical trials. But, out in real life, we end up giving that vaccine to potentially millions of patients. So this post-marketing monitoring by the REMS program helps identify any really rare, really serious potential issues. Again, these are non-preventable adverse reactions. They analyze reports, they identify trends. It is not mandatory, but certainly encouraged. Drug approval process. So I did want to break this down a little bit further. So this is really ultimately under the FDA umbrella. So we've got, discovery of a new potential agent that may be beneficial, development, studying that medication in non-human. So this is kind of called preclinical research. And if, the results are good enough, or we think that there's a potential significant benefit in humans, a group or a company can apply and receive an investigational new drug approval. And following approval of that, there's 3 phases of clinical trials, and I'll kind of talk about those a little bit more, as well as phase 4, which is after approval. But let's break down those 3 phases as well as post-marketing. So after, again, receiving the IND, the investigational new drug application approval, we start into the clinical trial phase. So phase 1 clinical trials is going to involve a really small number of healthy volunteers. Okay, and if you think about it, we really don't want to give a new medication to frail patients with the disease states. We want to make sure that we're giving in the clinical trials the medication to healthy volunteers that can potentially not be substantially negatively impacted by an adverse effect. So in this phase 1 clinical trial, again, small number of patients, and we are looking at safety and dosing primarily. Okay, and we usually do this just kind of for a few months, just to ensure that the medication is safe and that the dose we're using doesn't provide an excessive amount of harm to the patients potentially. Now, if all goes well there in phase 1 clinical trials, no obvious issues, concerns, phase 2 clinical trial, here we start to look at efficacy. Okay, so here we're going to give this medication maybe up to several hundred people, and these patients have the actual disease that we're trying to treat with the medication. Now, phase 2 clinical trials, this may last anywhere from a few months to maybe a couple years even. And again, we're going to look at efficacy here, or start to look at efficacy, and then of course we're going to have adverse effects and safety involved there as well. Now, if you clear phase 2, everything's going well, the medication's appearing to be overall relatively safe. It appears to be relatively effective to the disease state. Phase 3, we're going to give this medication to a much larger number of study participants. So hundreds to potentially thousands. Again, this is going to be based upon the rarity of the disease potentially. Are you able to find that many study participants? Which might be harder in a disease like MS versus a disease like hypertension or diabetes. Definitely would be easier to find study participants because there's more patients with type 2 diabetes versus MS for sure. So again, those exact numbers are going to vary a little bit, but phase 3 will obviously have the highest number of study participants. Often, these studies can drag out into the time frame of years. Again, efficacy and adverse drug reactions. So phase 1 is kind of that initial safety profile in younger, healthier volunteers. Phase 2 is kind of a small group or a few groups of patients looking at efficacy, maybe in the low hundreds range. And then phase 3, we ramp up and give it to hundreds to potentially thousands of study participants, and generally going to last a longer period of time. So now you've got all the data put together as researchers. You've got your phase 1, 2, and 3 clinical trials done. Everything's looking great. That's submitted to the FDA, and it's a new drug application. And if everything goes well, that drug is approved. Now, following approval, we're going to do phase 4, where that drug is actively being used in clinical practice, and we're going to do post-marketing surveillance, looking at safety, efficacy, and here's where you really get the rare adverse effects, adverse events reporting. Okay, so and this is why medications get a boxed warning, or we find out years later that there's issues with a certain disease state. So a classic example is like rosiglitazone, Avandia. This medication had substantial risks in heart failure, and due to that, the drugs can either be removed from the market or have significant restrictions. Darvocet, another medication, propoxyphene, that was removed from the market, or Darvon is propoxyphene, I guess, but medication was removed from the market due to substantial risks, as well as minimal efficacy associated with the medication. So that happened in phase 4, kind of post-marketing, after the fact, after the medication has been approved. Generic drug approval. So generic drugs do not require clinical trials and the same phase 1, phase 2, phase 3 clinical trial process that new drugs require. All generic drugs have to do is get approval on the bioequivalence side of things. Okay. With that, generic drugs are not approved by an NDA. Okay. Remember I said after phase 3, an NDA is submitted, a new drug application. Now generic drugs are approved by an abbreviated new drug application. Okay, that's how generic medications are approved. MedWatch, so this is an FDA program. There's a form, 3500B, that consumers can fill out and report serious reactions from medications. If there's concerns on quality as far as product malfunction, different devices, things like that. I think of insulin pens. I think of inhalers, things like that, as far as from a device perspective, nebulizer machines. Patients, consumers, healthcare professionals can report those issues on that 3500B form. Really, MedWatch, this FDA program, this comes into play as far as that phase 4 monitoring, where, okay, we're seeing a significant number of patients are reporting this side effect with this medication. We didn't really catch this on the clinical trial, maybe phase 2, phase 3 clinical trial side of things. But this definitely is an issue. Looking at those MedWatch reports, the FDA might look at that and say, okay, well, what should we do about it? Should we put certain restrictions on this medication? Should we, inform the manufacturer, and they can do things as far as different programs, restrictions, and submit that back to us. And I'll talk a little bit further about that process going forward here as well. CBER, different from CDER. This is the Center for Biologics Evaluation and Research. So as we know, the biologic market is certainly growing. They fall under the FDA umbrella, just like CDER, the Center for Drug Evaluation and Research. CBER is responsible for biologic medication approval and also biosimilars. Now we're starting to get a few biosimilars, and certainly we'll get more and more over time. CBER is responsible for that, as well as the monitoring, ongoing monitoring of these products for safety and things of that nature. So REMS, you may hear that program. So this is the Risk Evaluation and Mitigation Strategy. So these programs are set up to ensure that the benefit of the medication outweighs the risk. And it's used for very specific medications that pose significant risk of adverse effects, problems, side effects, or potentially a small risk, but of very, very serious problems. Okay, so kind of the classic examples here is clozapine. There's a registry, a process. Patients must submit to doing lab work. White blood cell count. Again, neutropenia from clozapine is not incredibly common, but it's a significant, serious, life-threatening interaction. Okay, or reaction. Excuse me. Isotretinoin, another classic example that requires a REMS program. So patients must prove that they aren't pregnant and do pregnancy testing to get their release or their refill on their medication. So again, these REMS programs, they can, really have varying degrees of restrictions, and that degree of restriction is based upon, how great is that risk compared to the benefit of the medication. So just talking a little bit more about the REMS program, really it's on the ownership. So I kind of talked about the FDA and MedWatch and identifying some problems and some trends. The FDA, if they identify particular problems with a product, they're going to go back to the manufacturer and say, hey, we're running into these issues. I think, we need to change something. And from that, the manufacturer can develop a REMS program where maybe it's restricted use based upon safety and other issues. So the drug sponsor or the drug company that produces the medication is really, the ownership is on them to create a REMS program if the FDA deems that a medication isn't safe for kind of standard prescription processes. So FDA reviews and approves those programs, but the drug company is responsible for kind of generating it and creating it. REMS program generally developed based upon the risk of the medication. Again, clozaril and isotretinoin are pretty intensive, where the patient has to do lab work, to get the refill of their medication. It can be, so REMS programs can be a class of medications, or it can just be a specific drug. So clozapine, that's kind of a specific drug versus a class effect there. May be required upon initial approval. So FDA can require it kind of once that new drug application is submitted, or phase 4 clinical monitoring. If we start to identify problems, FDA can do it kind of retrospectively too. REMS medication guides, so those explaining the program needs to be developed by the drug sponsor, and that needs to be in patient-friendly language as to why there's risks associated with the medication and why the procedure that the patient needs to do needs to be done. ETASU, elements to assure safe use. So this may be part of the REMS program, kind of further breaking that down. It's the task that needs to be completed. It definitely can be time consuming for patients. It may require special training, special administration, lab testing. Patient may have to enroll in a registry. Lots of different medications have different requirements. And, I think of Suboxone kind of requiring specific training. Only specific providers can prescribe that medication, for the treatment and addiction. It's kind of a little bit of a different scenario, but I think you get the point. Certain trainings may be required of clinicians before they use a medication. I had one the other day where they were talking about long-acting injectable olanzapine, and that requiring special, basically monitoring special parameters and special training to be able to give that medication. NIH, so there's another kind of governmental agency. They're really responsible for biomedical research. They fall under the Department of Health and Human Services umbrella. They do a lot of clinical trials that are, funded by taxpayer expense. They may be very helpful in clinical trials for generic medications is kind of the way I think about it, simply for the fact that, drug companies don't really have a strong vested interest in doing research on generic medications. Why? Because they're not going to benefit financially from doing that type of research. So NIH might be really helpful in those type of situations where we are looking at generic type medications and which one is better. And really the goal is to enhance knowledge, understanding, help develop best practices within the medical community. Institute of Medicine, they're most well known for the To Err is Human report. It really opened up the discussion, the transparency as far as medical and medication-related errors, and really meant to enhance. The goal was to kind of open the eyes and enhance the environment of kind of continuous care and improvement, development safeguards where there needs to be, and really shifted focus of medication errors to systems and processes versus, labeling an employee incompetent, for example. HQR, Agency for Healthcare Quality and Research. So this falls under the HHS umbrella, Department of Health and Human Services. They foster evidence-based medicine in making, healthcare safer, more affordable, equitable, those type of things. Joint Commission looks to AHQR to help develop the research as far as best practices, highest quality, cost effective, all those different things. So again, AHQR is a government agency under the HHS umbrella, and they help identify some of those best practices based upon the best evidence we have. Accountable care organizations. So this is really a group of medical professionals, hospitals who kind of voluntarily commit to providing high quality, highly coordinated care to Medicare patients. And the ultimate goal is an attempt to reduce costs, avoiding duplicate services, lab work, things of that nature, and minimize excessive care. Also, accountable care organizations really have a duty to provide care in the least, in the most cost-effective manner. So, not hospitalizing a patient who doesn't need to be hospitalized, finding ways to treat that patient without sending them to the emergency department or the hospital, if it's appropriate. Now, if it's not appropriate, certainly we use the emergency department and hospital. But finding ways to do more preventative things is, usually a highly important thing that accountable care organizations do. Payment models are shifting to quality of care reimbursements, not necessarily fee for service. So that's definitely been a shift over the last 5-10 years, and I believe will continue to be the shift where accountable care organizations get paid to take care of that patient, and that allotment and how much that payment is going to be based upon the disease state that we're treating. And you need to be able to figure out, as an accountable care organization, how to best deliver that care in the best manner and the most cost-effective manner. National Quality Forum. So this is another agency that kind of provides guidance on standards, quality measures. They endorse different quality standards and quality measures. They also make recommendations of quality measures that should be incorporated into payment models. So again, a lot of the accountable care organizations are being required to meet certain standards. If they don't, meet a certain percentage of patients that are adequately treated for diabetes, whether that's, goal A1C of 8 or less or 7 or less. If if they don't meet those percentages, well, then they can be disincentivized by payment models and potentially have to pay more in or lose payments because of not meeting those quality measures. So the NQF, the National Quality Forum, helps recommend and choose some of those quality measures that are incorporated into those payment models. NQF also is a source for provider and healthcare tools as far as reports, guidance on how to improve quality and meet some of these standards that are being set. Meaningful use, so this has to do with relation to electronic health records, just the implementation of electronic health records for improving quality, safety, sharing of information, care coordination, all that good stuff. Meaningful use electronic health records really provides a great benefit to population health, where different healthcare organizations can communicate. You think about something simple like getting a vaccine. Okay, is that vaccine being reported to a place where all healthcare organizations can see that information? Okay, that's a really important thing and part of the meaningful use in electronic health record information. Again, sharing information allows patient access in an efficient manner, where patient can get access to their medical records, allowing communication between different healthcare professionals. Also allows for better tracking of quality standards, quality measures, and things of that nature. Educating healthcare professionals, educating patients is an important thing we do as pharmacists. So I did want to touch on this briefly, presenting materials, whether that be written, whether that be verbal, whether that be a presentation. It's important to know who your audience is and ensure that the information, the presentation that you're providing matches that education level. So when looking at giving patients materials, presenting materials, what is the objective? Is there a specific need? Does that patient need to be educated about a medication? Are we looking at training staff about a particular medication administration procedure because we've identified weaknesses? Okay, looking at the audience, looking at the objective of what we're trying to do. And then further, how are we going to assess that education delivered? So take the example of a patient using a GLP-1 pen. Okay, how are we going to educate them? We're going to want to use patient-friendly language, maybe give them an instructional video that they can have access to after you've demonstrated it to them. Maybe it's a PDF handout that really shows visual steps. And then following that education and providing that education, how are we assessing that education was adequate? Okay? And so the classic example in patient demonstration is, can they do it themselves? Have them show you how to do it. That's kind of that classic feedback mechanism where they, or a teach back mechanism, where they show you how to do it, and that gives you the confidence that they know how to do it. As far as, if we're training staff members on appropriate administration of a new medication, new device that maybe they've had issues with or concerns, we can certainly do some sort of testing, whether that be a multiple choice test. Maybe that's appropriate in certain situations. Again, maybe having them show us, demonstrating how to use that device is a good method as well. So again, looking at who's the audience, what the objective is, and then did our education make a difference? Have we shown improvement? Barriers to providing education, this is probably a little bit more so on the patient side of things. Language barriers. Is there cultural barriers going on? Educational barriers. Can that patient not read, not adequately understand and follow instructions? Is there hearing difficulties? Are there visual impairments? Cognition concerns? Do they have borderline dementia or mild dementia? That's going to impact that education that we're providing. So really, really important to think about all these issues when providing any type of education. OSHA, another kind of organization. OSHA, Occupational Safety and Health Administration. This group really sets out to protect workers in general, but obviously in our setting of hospitals, clinics, pharmacies, it's meant to protect healthcare workers' safety. Okay, so OSHA looks at kind of standards for definitely riskier type medications. So handling, administration, storage, disposal, transportation. So is there risks in being around that medication, in storing that medication, in administering that medication, and what should be done about those risks? So the classic example is chemotherapy, and it's why we have specific handling procedures. We don't want healthcare workers unnecessarily, excessively exposed to chemotherapy and the issues that may surround there. So OSHA kind of handles a lot of that workplace environment safety. Also things like sharps and needles, needle stick, all sorts of different exposures there that healthcare workers are exposed to. All right, here I'm going to talk about some pharmacy legislation, just some real basics that I think it's good for pharmacists to know. So first off, Biologics Control Act, so 1902. This really ensured safety and purity of products that were used to treat and prevent diseases. So allowed kind of for that tracking of safety as well as the production of the products being given to patients. Food and Drug Act of 1906. So this prohibited interstate commerce of adulterated and misbranded drugs. So you can imagine drugs that were adulterated, considered expired or inappropriate to use in patients. You could imagine how selling them to another state that might use them would be a possible problem. You could potentially foresee that. 1938 Food, Drug, and Cosmetic Act. So new drugs approved must be proven safe. Okay, so this is the first time that we've had a proactive type of process where drugs approved must be proven safe first and foremost before they can actively be marketed and given out to patients. This also prompted the look at factory inspections as well in 1938. 1951 Durham-Humphrey Amendment. So this is really where our OTC and prescription separation began. Kefauver-Harris, 1962. This really ensured efficacy and really enhanced safety. And the reason that this amendment came out was, if you remember the Billy Joel song, where he talked about children of thalidomide, there were really, really serious, severe birth defects from thalidomide use in pregnancy. And so Kefauver-Harris, really set out to ensure safety as well as efficacy of medications. Tamper-resistant packaging, if you remember in 1982, if you remember hearing about that, Tylenol cyanide poisoning happened, where basically somebody opened up Tylenol bottles and put cyanide within those bottles. And so this is where tamper-resistant packaging became kind of standard practice. Orphan Drug Act 1983, so this is really the promotion by the FDA to for drug companies to look at more rare diseases. Orphan drug is considered in conditions affecting 200,000 patients or less, really provided some additional financial incentives for drug makers for rare diseases. Prescription Drug Marketing Act, this required wholesalers to be licensed. It restricted also re-importation of drugs, and some potential concerns with adulteration and misbranding there. Also banned the sale, trade, and purchase of drug samples. You can imagine that there may have been a black market on drug samples if drug companies were giving these away to healthcare professionals or different individuals, and they were potentially selling them illegally. Bans diversion of prescription drugs from commercial channels as well. So kind of creating black markets for prescription drugs. MedWatch, so this was initiated, I kind of talked about that program a little bit before, initiated in 1993, kind of for that monitoring and tracking. DSHEA, This was the Dietary Supplement Health and Education Act. So this was important legislation as far as stating that dietary supplements are considered food and not medication. Okay? So this did allow the FDA to encourage good manufacturing processes for supplements, but it does not require annual or routine FDA surveying of those institutions, of those factories. Okay. Now they can go in and look at those if there's concerns, if there's questions, if there's shady manufacturing processes reported, they can go in and look. But as far as kind of routine tracking, monitoring of supplement production, it's a challenge for sure for the FDA because there's so many. But this legislation in 1994 classified dietary supplements as food and not medication. So it doesn't need to go under this strict clinical trials and all that whole process for dietary supplements. FDA Modernization Act in 1997, so this regulated off-label advertising. Medicare Part D, created in 2003 and implemented in 2006, certainly an important piece of legislation as far as prescription drug coverage in seniors. Affordable Care Act in 2010, so this is Obamacare. Few provisions, children remain on their plan until 26. Set up a fee, a tax, or whatever you want to call it for not having insurance. CMS Innovation Center was also created to really create guinea pig models as far as healthcare models that might help reduce cost and maximize service and ultimately help improve healthcare. MTM model was one of those that received some expanded testing from CMS Innovation Center. IRB, so just kind of, talking a little bit more about this kind of within a healthcare organization. IRB is an institutional review board. They are responsible for monitoring, reviewing, approval, and approving research within a healthcare organization. And they really focus on making sure that patients are not subject to excessive risks associated with any type of clinical research. Okay, so institutional review board, they kind of look at informed consent. What's the proposed study? What kind of patient education is being provided, and really weighing the risks versus the potential benefit of the study that's going to be conducted. IRB, a little bit more about them. They need to register with Department of Health and Human Services if doing FDA type research. The IRB does not have to be set up by the institution. They can have an outside institutional review board. And if you think about that, maybe for smaller institutions where, the numbers of healthcare providers, people available, maybe that is an issue. So maybe they kind of outsource that IRB. IRB members can be paid. Certainly conflicts of interest should be considered when selecting members. So if you've got somebody that works for a pharmaceutical company and we're talking about doing a study for that drug that a pharmaceutical company makes, certainly you could see how there's a potential conflict of interest there. IRB members, we need at least 5, varying backgrounds, and we need more than one profession. Okay, you can't have all nurses on the IRB. You can't have all physicians on the IRB. We need a mix of men and women. This is a recommendation. It's not a requirement, but certainly having both genders there, having some representation, getting different perspectives, I think is an important thing to consider there. One member has to have a kind of a scientific research type background. One member also has to have a non-scientific type background. A P&T committee. So this is an interdisciplinary team made up of nurses, pharmacists, physicians, administrations, quality personnel, other providers, and so on. Their primary responsibility is looking at drug formulary, updating formulary, basically things in association with medication management, medication standards, best practices. So if guidelines change in relation to medications, updating our hospitals formulary, institutions formulary as to what's the best practice, most cost-effective drug therapy. Reviewing, like I mentioned, that new literature, also reviewing new reports of adverse drug reactions. So if a boxed warning comes out, if there's medication errors that are occurring, if there's processes that need to be changed surrounding the use of medication, risks, guidelines, and so on and so forth. So P&T really focuses on standards, practices, errors, patient safety, all in association with medications. MUE, sometimes called a drug utilization review or medication use evaluation. This is really an analysis of a medication use process, kind of from start to finish, from prescribing, ordering, preparing, dispensing, administration, and monitoring, kind of that whole workflow surrounding a medication being utilized in the hospital or in the healthcare setting, and looking at the whole picture from acquiring to prescribing, administration, and after the fact monitoring. Goal of kind of a MUE is to prevent errors, prevent injury, kind of maximize safety, support clinical practices, continuous improvement, identify areas of weakness. That's an important part of the medication use evaluation. Minimize costs. So, this drug is available orally, but we're using a lot of it IV, which is way more expensive. Can we use more of the oral medication, or is there issues in relation to adverse effects and weighing that risk benefit type thing of the costs of medications. Also, we may look at medication use evaluation as far as regulatory requirements. Maybe there's new standards now. Maybe there's some high-risk data evidence that has come out at other institutions about using a particular medication. Well, maybe that prompts us to do a DUR or referred to as a MUE as well.